Hi, everybody. Welcome to today's webinar. We're really excited to get started with you. We do want to give some time for others to join the webinar as we have just opened up the session. So please be patient for a moment or two, and then we will begin the webinar. Thank you. Welcome to everybody who has joined. We're still seeing attendees continue to flow into the webinar. So we would like to wait maybe another 30 to 60 seconds before we begin to give everybody time to join us from the get-go. So thank you all very much for your patience. Okay. I feel like we've had enough folks join that it makes sense for us to begin, and those that come late, we will deal with it at that point. Welcome. My name is Joe Sasson. I am the Executive Vice President of the Ventures Department at MedAxiom, and thrilled today to bring you this webinar. Before we begin, and before I introduce our speakers and the topic, what I'd like to do is just make sure we're providing you an overview with how to function within today's webinar. What you can see at the lower right-hand center right of your screen is a Q&A button, and that is how you can send any questions either to the presenter or to the staff if you're having any kind of issues with your audio or visual. You can communicate with presenters and staff through the Q&A button. Now, the chat button you'll find kind of center left, and the chat button is a way that you can access the slides. That chat button and chat box is not open to everybody during the webinar to make public comments, but it is a place where you will see slides appear. Now, if somebody joins after slides have already been shared through that chat box, they wouldn't see them. So what you'll see throughout the session is multiple times we will be inserting the link to the slides. So every time you see that chat box have another little icon that there's a new message there, if you've already downloaded the slides, it would simply be the same message throughout. So there's no reason to continue to go back, and those slides are going to be the same every time. So if you have any questions, again, the Q&A button is where you'll be able to ask those. So moving forward, I'm very excited about today's webinar. The reason is everybody that's presenting today has been in cardiovascular care in some way, shape, or form for quite a long time. And the topic today is fresh approaches to cardiologist alignment. When I came into the field of cardiovascular medicine in the early 2000s, 98%, it seems like, of all groups were privately owned. And the hospital ownership or a hospital PSA model was by far the minority, maybe 1%, 2%, 3% of practices all over the country. And then things started shifting in 2008, and they've continued to shift to where I'm going to say maybe in 2019, 2020, we were at a point where we were 80 to 90% integrated with hospitals and health systems, with 10 to 15% of the groups that were still operating under a private ownership model. And what has happened is that we've then seen the introduction of private equity into the world as well, where now there's MSO platforms and private equity platforms that people have been able to partner with as well, leaving us with a ton of options, from employment to closely aligned PSAs to affiliation with a private equity platform, or maybe working with an MSO that doesn't buy into your practice. And the way that we integrate and work with our hospital partners has changed, whether we're doing co-management, whether we're doing directorships, whether we're just doing joint ventures around ambulatory surgery centers. So the models that were once fully private to then a little bit private and fully employed or closely aligned PSAs have now expanded into a variety of ways that folks are working together, that they're legally aligned, and how they're strategically and operationally aligned. So it really has been just quite the journey, and the options today are more than they've ever been, I think, ever for cardiovascular physicians and program leaders, with many dynamics about how to manage current state and especially new components of cardiovascular care like ambulatory surgery centers, which are really still fairly new, 5-6 years old in the CV field. So really excited today to help bring some clarity, some strategic options, and some overview to those different options that we have out there in medicine today. And by doing that, we're bringing in two attorneys that I've worked closely with for a number of years now from Baker Donelson. The first is Gary Hirschman, and Gary has been a regulatory and healthcare transactions attorney, done deals with hospitals, PE firms, ASCs for 35 years now. And Anjana Patel, who has also done regulatory and healthcare transactions with all those same stakeholder groups for 25 years now. And I say that to her credit. Anjana was not trying to do anything other than give you the due experience that you've deserved. So with that, I'm just really excited for the content that they have today. And then I do want you to use that Q&A button throughout the webinar. If you have any questions, I will interject them in as near of a real time as appropriate. So to get us started, because people didn't come to hear me, Anjana, I'd like to turn it over to you to take us away.
Thank you, Joe. And let me start by just kind of laying out the agenda, the different models that we're going to be speaking about today. First up is co-management models. I'm going to say a few words about that, and then Gary's going to jump in on joint venture opportunities with respect to outpatient facilities like ASCs. And then he's going to talk about some sort of variations on the professional service model involving private equity-backed cardiology practices. And then he'll turn it back to me, and I'll speak a little bit about hospital MSO arrangements with physician practices. So let me kick off with the co-management model on the next slide. So, co-management models have been around for decades. And basically what this is really a partnership between hospitals and physicians to jointly manage a particular hospital service line, with the goal being that that service line will improve over time. And the reason why this model has been around for decades, and I think, to what you were saying, Joe, when you were thinking back to 2003, 2008, I think this model was around, beginning to come around at that time. And then, over time, it has really kind of evolved along with sort of developments in care delivery and technology. But why has it been so popular and successful? The reason is because it has a proven track record in improving hospital physician integration. And it has the hallmarks of the sort of triple aim of value-based care, right? Improving patient outcomes, reducing cost of care, and overall improvement in patient experience. And as the value-based sort of care delivery and payment models were developing over the last few decades, this was kind of seen as a model that's a kind of lower risk but practical entry point into value-based care, right? It's like a starting point towards sort of more developed and advanced value-based care models. So it has been around for a while. It's proven to be successful. And the reason is, like I said, it has the value-based components, but it also has benefits for all the parties involved. If you look at it from the physician's perspective, they get to actually have meaningful control over the clinical service line, which affects their day-to-day, right? And the reason why it's also popular is because it enables the physicians to financially participate in their work towards improving that clinical line. And we've noticed over the years that, especially with employed physicians, this model is really opening doors for the younger physicians to have leadership opportunities and, like really demonstrate like they can take ownership. And that's been a sort of career advancement type of, I'll say, retention, recruitment side benefit from this model. From the hospital's perspective, this is, where they really get to kind of improve the collaboration with their physicians. They get to improve quality of care through, standardization of protocols and, using best practices across the board in that service line. And really also try to improve the cost savings, because here, when you're jointly managing a service line with physicians, the hope is that encourages the physicians to be more mindful of how they use resources, and then hopefully that results in more cost savings. So, it has benefits for the doctors, it has benefits for the hospital, and, hopefully the patient also benefits because better outcomes and a better experience. I will basically go through the two variations of how these models are set up. One is through what we call this operating committee model. Here, what happens is the hospital and the physicians essentially set up a committee, whether it's an operating committee or a steering committee, but it's a committee. Each side has representatives on the committee, and the committee is charged with the sort of general day-to-day management of the service line. In this model, the service line contract, which is the actual co-management arrangement contract, is between the hospital and each of the participating physicians or their medical practices. And it can be used also with employed physicians. So the employed physicians would, either have an addendum to their employment agreement, or they'd have a separate co-management participation agreement. On the next slide is the second variation on the model. And this is where essentially a joint venture management company is set up. So this is a new legal entity that's set up, and it's owned in some cases entirely by the physicians, but sometimes the hospital may also be an equity participant. And we see that usually in the case of co-management arrangements that kind of cover broader services, so along the spectrum of the entire cardiovascular service line. So for example, if an ASC has to be developed and you want a capital partner, then the hospital sometimes becomes an owner so that they can get that resource in. But essentially what in this model happens is that the joint venture company has the actual service line co-management arrangement contract with the hospital. And one thing to keep in mind with this model is if you are involving independent physicians, you have to decide how those physicians will participate. Sometimes it's individually, sometimes they participate through their group practices. And so additional sort of safeguards have to be built into this model to make sure that when they, as a group practice, are admitting new physicians, there's sort of a trickle down of certain obligations and responsibilities and compliance down to the new participants. But this model, I think personally, is more popular than the other model because there's something about equity participation that is it's desirable, and I think that it helps, especially I think in the employed physician world, if those doctors have the opportunity to have equity participation. If the physicians are independent, meaning they're not employed physicians, then they retain their independence with respect to all their professional billings. So anything they do, in their offices or outside of the hospital, that's all, outside of this arrangement. And similarly, the hospital, retains all its billings for technical and anything else. And the hospital essentially, retains overall control of the service line. And for because it has to, because it owns it, and also for compliance reasons, it has to have that control. In terms of structure, I would say that, the hospital is essentially outsourcing components of this service line to the doctors. So it is expecting like some meaningful performance to be achieved. But on the flip side, the doctors are spending a lot of time towards, that improvement in performance, and so that time, might take away from clinic time. And so this model works best if it's spread out over a larger group of participating physicians, because it does require that the physicians individually spend meaningful time towards achieving the goals of the arrangement. So, if that burden is spread over a broader base of doctors, we find that, that helps with the success. The service line contract basically is basically an agreement that sets forth the services that will be provided, which are essentially management level services. So the doctors are managing that service line, whatever the components of that service line are. And the goal is that those efforts will result in movement in certain metrics attributed to that service line. And as a result of that effort, the physicians are paid a fee. And the fee is essentially broken into two buckets. The first is a baseline compensation fee. So that's usually like for these management services, and it's usually like an hourly fee. I feel like, sometimes people say co-management. I mean, that's very much like a medical directorship, right? Like a medical director helps manage certain aspects of the clinical service line. But it's not like a medical directorship, because that usually involves one or maybe two, individual physicians. Co-management is really like a team of doctors that are working together. They're coordinating with the hospital, and they're like putting in some in-depth, meaningful effort and services towards, that improving that service line. So it's more in-depth, it's more involved than a simple medical directorship. And obviously, nothing against medical directorship, but I just want to point out the differentiation there. And what these management services can mean, or can include. We've seen things like, participating in strategic planning initiatives with the hospital, developing program and protocols for the service line, educating physician and non-physician staff, developing policies and procedures. I mean, it's a full range of things that doctors basically can get involved in. The second component of the fee, which is tied to metrics linked to performance improvement. Now, this is incentive compensation, so there's no guarantee that the physicians will earn it. But the goal here is, you have some preset metrics that the hospital and the physicians collectively work together to develop and establish. And that's the baseline. And they can be based on a variety of things: operational efficiencies, patient satisfaction, program development, clinical outcomes. The key towards setting these metrics is they have to be meaningful, and they have to be measurable, and they have to be comparable to like industry benchmarks. So, the compensation cannot be tied to metrics that the hospital has already achieved in the past, or they might have achieved it recently and it's more of like a sort of maintenance metric. Sometimes you can have those maintenance metrics if they're super important to the hospital, but for the most part, the metric can't have already been met, right? This is like, we're looking for improvements, so the metric has to be something that you have to strive for. And for this reason, the term of these contracts is usually 2 to 3 years, because they have to be continuously monitored, and they have to be reset if the metrics are met over that time period. And often we get the question, well, these, we had the initial work done to set the metrics, right? We spent a lot of time with the hospital and the physicians to come up with these metrics. And like, okay, we're doing really great. We're meeting all these metrics. Are we going to run out of metrics? I don't think you can ever run out of metrics, honestly. And this is kind of tied back to why this model is so popular. It has been for the last, whatever, 20, 30 years. It's because it works in tandem with developments in care delivery and technology. So I'll give you some examples of some of the things that I've heard kicked around in terms of, can we have a metric around this? One of the things is, as more and more cardiovascular procedures are moving to the ASC, we're seeing like the scope of the co-management arrangement, cover more things. Like earlier on, I would say that a lot of the co-management arrangements were focused on just one aspect or one component of the cardiovascular service line, like the cath lab. Now you're like seeing more and more things being captured, and you're seeing like it moving to the outpatient setting. So that's one development over the years that we've seen. Another is around technology, because technology is now so key. It plays such a key role in everything. We're seeing, for example, like, can we have metrics around remote patient monitoring? Can we have metrics around wearables and virtual or home-based care? I mean, the things that, that are tied to all the sort of technological related advancements, we're seeing that people want to include those as metrics. We're also seeing, like, recently I heard somebody ask, there's such a growing emphasis on using, GLP-1 therapies as part of cardiac care management. Like, can we have a metric around that? I'm not the actual consultant that sets up the metric, but I can see how that can be a metric too, right? Anything around disease prevention can be a metric as well. And I also think the other thing that we're seeing a lot of in cardiology is that a lot of the advanced diagnostics like PET, MRI, 3D echo, all that stuff is being used more and more. And you're going to see metrics developing around some of that as well. And then lastly, I would say that the other thing that we've seen over the years with these models is as the care becomes more holistic, with like greater coordination with primary care and other specialists, like we're seeing, whether we're seeing hospitals and physicians consider metrics around collaborations. Like recently, I was talking to somebody about a collaboration in women's health. Women are getting mammographies, and some of them are getting an optional diagnostic done for breast arterial calcification. I can remember the words, but that was the test. And the question was whether doing that test and whether that helps with the sort of the cardiology aspect of the person's health. So there's lots of different things that can be metrics. So I just wanted to, point that out. I will also say that metrics don't have to be weighted equally. Like some metrics can be weighted more heavily than others. There's a lot of flexibility in how you set this up. And also in terms of how much is paid as the base compensation versus the incentive compensation, there's a lot of flexibility there. Some of these arrangements are 50-50, so 50% of the compensation is towards the management duties, the rest is on the incentive side. Some of them are more heavily on the management side, others are more heavily on the incentive side. And it just depends on the particular hospital, what they're trying to cover in terms of this co-management arrangement. So I think lots of flexibility in how you structure these. It's a lot of sort of baseline work to set the initial metrics. There's a lot of collaboration in and of itself to set those up. But once they're there, I think this can it's easier to maintain and monitor and reset once you do that heavy lift work in the beginning. I'll just end by saying, from a legal perspective, these arrangements, they're easily or can be easily set up from a legal perspective. I mean, And I mean that by compliance with the federal anti-kickback statute, the Stark law, and the civil monetary penalties law. Those are the three main laws that come into play when you're trying to structure around these things. But there are other issues, tax exemption issues for the hospital. There might be antitrust issues in some cases, but as long as the compensation is fair market value, the metrics are reasonable, you're not paying for performance that has already been achieved, then there's a way to structure easily around these things. So that was co-management in a nutshell. Let me turn this over to Gary to talk about PSAs, joint ventures. Sorry.
Right. So thank you, Anjana. It's very helpful discussion. I want to just kind of rewind back to what Joe was saying, that just to kind of as an intro about joint venturing for ASCs. The cardiologists have a lot of options nowadays, as Joe mentioned. And, as hospital executives from the hospital perspective, you want to both keep close relationships with your community physicians, the private groups in the community, and you want to keep good, relationships with your employed physicians and physicians also under PSAs. When I say employees, you can also say, under PSAs. And when I say PSAs, I mean all of a cardiology group services are all billed through the hospital physician enterprise, like a full-blown PSA. And so I think it's important to look at that from both the community physician perspective and the already aligned physician cardiologist perspective. There have been surveys over the last couple of years that on the employee side, as we all know, close to 80% of cardiologists are employed, by hospitals mainly. And so, but we're seeing in these surveys that 40 to 50% of hospital employed cardiologists are dissatisfied. And we've also seen surveys talk about how around 25% of hospital employed cardiologists are actively looking at options to go back into private practice, to separate from employment. And the reason I say that is that the top two reasons we're seeing dissatisfaction and or desire to leave hospital employment are, number one, lack of engagement. That the doctors just feel that they're employed and they're kind of put off to the side. They're not really engaged with, and they just, feel kind of ignored, and that they're just going about their business, and the hospital's not looking for engagement. That's why what Anjana spoke about regarding co-management is an excellent vehicle for engaging with not only your employed cardiologists and getting their bona fide input on improving the program and service line, but also community cardiologists, those few groups that are still independent. The second reason doctors are looking to leave hospital employment is they want an opportunity to participate in ancillary services. And with ASCs now, back before 2020, this wasn't really an opportunity for cardiologists. And it's since 2020, so the last 5 years or so, it's starting to grow in popularity. And so cardiologists, like all other surgical specialists that have been co-owners and getting dividend checks from ASCs for some time, see this as an ancillary revenue opportunity. And so they might want to leave because of this. So engage by proposing a joint venture ASC with your employed cardiologists and with cardiologists in the community, you're kind of being proactive and reaching out and saying, do it with us. We want to do this with you. We want to give you the opportunity to do this our cardiologist employees. And for the cardiologists in the community, we want to partner with you. Instead of you going off and developing, an ASC with some other company, do it with us. In other words, closen that relationship, make it closer, tighten it, and stay actively in discussions and alignment. So that's where the joint venture comes in. And basically, it's just investing in an ASC. So instead of the hospital just either doing an ASC on its own or continuing to have those services that can be performed in an ASC performed at the hospital, this is an excellent proactive model for, and the cardiologists have to invest equally. Everything's got to be pro rata for regulatory compliance, as you know, but it's really a great opportunity. The other with doctors with PSAs with hospitals, I've actually gotten a couple calls from cardiology groups that are in these close PSAs where they feel like they're dissatisfied because they feel like they've been shorted on their PSA payments based on work RVU calculations and not getting what they're entitled to and whatnot. So again, that's another mode of dissatisfaction that we're starting to see a little bit. But again, coming together for an ASC just between the hospital and physicians is clearly one way to get closer and strengthen the alignment. So on the next slide, the other option is to do this instead of just with the hospital, the physicians, adding one or two other players, which is an existing ASC operator. And I think you've seen a lot of JVs, a lot of physician groups have joint ventured with ASC operators. And with regard to other ASCs, hospitals, physicians, and ASC operators have joined together. Like USPI started the model where they joint venture with a hospital and own together 51% of an ASC. But we've also started to see investors. Like when I say investors, I mean like private equity investors. We think that's going to be a new trend. We're starting to see it, not in cardiology yet, but there was a big announcement last year where the Hospital for Special Surgery, which is an orthopedic specialty hospital in New York City, entered into a joint venture. Their orthopedic surgeons who were employed, as an analogy, wanted to have ownership in an ASC, and a good number of them were really pressing for it and thinking about leaving. And so here they decided to do a joint venture. They did a joint venture with an experienced ASC developer and an investor, General Atlantic. And they actually they used this joint venture to purchase that ASC developer, called Legion. And now they have this four-way joint venture to develop ASCs and have their doctors be part of it. And it's a really good example as to where things could go with cardiology. So this is just another example of optionality, if you will, again, with your cardiologist employees, but also with cardiology groups under PSAs with the hospital and groups in the community too, to joint venture for an ASC. Joe, does anyone have any questions on ASCs before we move on?
Well, yeah, there is one that came through, Gary, and it's about partnering with employed cardiologists and independent cardiologists. And the question is it more challenging to joint venture with employed cardiologists than independent cardiologists?
My instinct is it's harder to do it with an independent cardiology group. They could do it on their own, right? They have other potential partners out there. Your employed cardiologist can't just do a joint venture while they're employed. They would have to actually leave employment, and some have done that. We're starting to see a little mini trend of that, going around where they could leave employment to join a cardiology platform or to go in an independent practice and then so that they could build an ASC. But I would think that if you do this with your existing employed cardiologist, I think it's a little bit easier because it's like they'll be so thankful that you're giving them this opportunity. And the only opportunity they would have is to leave to do it. Whereas the group in the community, I think it's still a very smart strategy to get closer aligned. But I think it's a little bit more of a competitive bidding, if you will. Like hospital, what can you bring to me that partnering with a private equity platform or this established ASC developer and operator, will have more ownership potentially if we do it with them than if we do it with you. Like what's the benefit? I think it's more of a negotiation. So I think it's easier with employed cardiologists.
Yeah, I think the ASC strategy, especially with employed cardiologists and the health systems and hospitals that employ them, this is really a recruitment and a retention strategy as well, because it's going to be hard to get them without giving them some dose of entrepreneurship, just employment. But it'd be even harder for those, especially that have integrated that were once in private practice, to not feel very comfortable going back out so they can participate in the ancillaries and the technical fees and so forth. So I think that if I were running a hospital or health system and I had a significant number of interventionalists and electrophysiologists, I would be trying to figure out how to do this with them before I lost them.
And they'd be so much more appreciative, right?
Yeah, I mean, it's
Especially if they enjoy being employed there and they don't really want to leave other than to have this opportunity.
Yeah, that's very helpful. Well, and if that didn't fully answer the question or there's others along this line, please go ahead and submit them and we will get to them as appropriate. Go ahead,
Sure.
Jerry.
So let's move on now to PSAs. Um, and it says here mini PSAs because it's how do you deal as a hospital with groups that have partnered with private equity platforms? That's the goal here. Okay, you tried to stay close and you've done what you could. Maybe some cardiologists leave nonetheless, or they've left already, or there's groups in the community that you've tried to align with and have gone to private equity. This is not the end of the world in either case. I know a lot of hospitals have this knee-jerk reaction to negativity when private equity comes into the scene, losing employees or losing, it's not really losing a group. I don't think you should view it as losing a group to a private equity platform. And the reason is that you still have opportunities. And we've worked with hospitals on contracting with independent groups and cardiology groups and independent groups that have partnered with private equity. I mean, they're still independent, even though they've partnered with private equity. And we've worked with them on both sides. We've worked with hospitals on these we'll call them mini PSAs, and we've worked with the groups that have decided to partner with private equity. And these agreements, if you can get past the knee-jerk negativity, provide an excellent opportunity to stay closely aligned with those doctors. In other words, even though you might not be happy about it, you should still be engaged because there could be competitors, hospitals in the community that that if you don't, embrace them to some extent, they could be embraced by a competitor hospital. So, and I'm telling you, almost 100% of the time, the doctors know that they want to continue this relationship with the hospital. And when I'm on the physician side, their first concern is we really, for an independent group, or even employed doctors, this is the best place for our patients. We love this hospital. We want to stay. We've grown up in this hospital. Our group and our doctors have been part of it for a long time. We don't want to upset them. We want to continue with to show our alignment, allegiance, and integration with them. And so, but you could do it through on-call agreements, medical directorships, other clinical duties, and like Anjana just went through for a while, co-management agreements. We have co-management agreements with these groups, even though they're partnered with private equity. We've worked this out, and it's interesting in that you could still, in the end, you could still be the same, almost the same level of alignment with respect to, using all of, the hospital for inpatients and cardiac surgery and so many things that can't be done in a private practice or in an ASC. And another way to look at this is, and I know some people, when they hear this, it'll be a little tongue in cheek, but it's really not intended that way. But hospitals have, or at least their physician enterprises have these statistics about how they have a loss per physician. Now, when they do that, they're looking at just the physician enterprise, what it costs to employ the doctors and what their professional services, personally performed services bring in. You can't count all the other stuff that's thrown off to the hospital, but there is a benefit to some extent to keep that close alignment and not have that loss at the physician enterprise level. So it really could be, if it's done right, nothing is lost, and some can be gained from embracing and working out, a very positive, aligned relationship with a group that's aligned with private equity.
Gary, I got another question come through. I think it's an okay time to address it. And this is, again, touching on the concerns that hospitals or health systems may have bringing in physicians as equity holders in the ASC. And the question is, do you see hospitals that are reluctant to offer their employed cardiologists an equity share due to concerns of loss of revenue, which is part of the facility fees, of course, and so forth, are going to get distributed to all shareholders, and concern of the hospital or health system for setting a precedent of revenue sharing for other specialties? So do you see hospitals very reluctant to do that? I can partially respond to this, but I prefer that you and Anjana do that first.
Yeah, so I'll take a first stab, and then Anjana, if you have anything to add, or Joe. But I think that part of this is that hospitals, to some extent, and you might say they don't need to do it with their employed cardiologists. They have that captured and locked in already, and so they shouldn't be concerned about it. But we are seeing this growing trend of doctors, of cardiologists wanting to maybe leave so that they can, participate in that ancillary revenue opportunity. So I think the answer is that the hospitals need to look at this more on a long-term basis. And retention, I think you mentioned that, Joe, retention on a retention basis, for recruiting new doctors. I think it's a phenomenal thing to do in terms of partnering with them. But yeah, is there going to be some loss of revenue? Yes. But if you go back 15 to 20 years, when you started to see the proliferation of ASCs, hospitals were fighting that, with other surgical specialties, and they didn't like it. But then what happened? If you can't beat them, join them. So, hospitals then said, okay, you know what? Instead of having our doctors just do their ASCs and us getting zero, let's align with them. Let's joint venture these ASCs, and having a good joint venture and a good alignment with them is gonna heighten and strengthen our relationship with those surgeons. And a really good example in particular is orthopedic joint replacement. Who would have thought 15 years ago that you'd be, doing full hip replacements and, with saws and all, right? Like it's on an outpatient basis, but it's now become customary. And, I think that hospitals have to look at this as there's still significant benefits to having half of something, than risk losing it all. And that the keeping the relationship close for many procedures that still can't be done in an ASC. I mean, a lot of these are bread and butter, but there still are a number of things that cannot be done in ASC. There are patients that are very elderly and frail that for other reasons, even though it could be done in ASC, it's not safe. So keeping that relationship and, you know, using the hospital's laboratory, imaging, all that kind of stuff, and inpatients. I mean, that's the story that needs to needs to make sense for the hospital, and they need to be open to that. I hope that answered the question.
Yeah, and I would just add, I totally agree with Gary. And, the part of the question that said, well, there's concerns about setting precedents, vis-a-vis other specialties. I mean, I think that's always been there. Like, going back to when ASCs first became popular, like that was a concern back then. Like, oh, are we going to have the GIs, do a joint venture with the GIs for an ASC? And what about the other surgeons? And so I think that hasn't changed over the years, and that's always going to be one factor to weigh in amongst all the other things that Gary said, right? So that's what I would say to that part of it.
Yeah, and Anja, if I could just add, like there's so many things, like even spine surgeries now are being done in ASCs, but there's always I mean, cardiac surgery is never, real like cardiac surgery and TAVRs and, other serious cardiac surgery. That's never going to be able to be done in ASC, at least that I can imagine, on an outpatient basis. So I do think that, setting a precedent, like Anjana said, it's already there. And even though the list is expanding with ablations now, right? With EP and ablations, starting this month or last month, this year. Again, I think everybody, you just have to, I think that's the direction of healthcare, going even to 10,000 feet above that. Everything's moving outpatient, and you could fight it as much as you want. But I mean, there's studies that ablations are even safer than cardiac catheterizations, in an ASC. I've recently been speaking to a client about that. So that's my sense too.
Yeah, I will say, because MedAxiom does have an ambulatory surgery center joint venture, MedAtlas CV, just focused on cardiovascular ASCs. And I can tell you that nearly all of those conversations start with a health system saying, hey, this is something that we can do. It's just another place of service. They have the office, they have the hospital, they have the ASC, and we'll just create the schedule to do that. And every single one of those conversations and deals, by the time they got finished, involved physician equity participation, every single one. So there is, I think, some retention aspects. They understand they're going to be giving up some things. They understand they have to backfill the labs. And they understand that, yes, maybe this does go to other specialties. But if the model works in one, and you get the benefits that you hope for in CV, you also get those benefits in urology and pain and ortho and everywhere else. And that is a model that health systems I have seen embrace across all of those specialties. So there really is a thinking inside the health system and their strategy for ambulatory services that should probably remain consistent. And yes, it does mean involving physician shareholders in all of the ones that I have seen executed effectively. But it does take usually a cultural change, because not everybody would see that this should be a hospital-owned endeavor completely. But somebody, one of 10 at the table or 5 of 10 at the table, may feel that way. And through group discussion and discussion with all stakeholders, they normally, what we have seen, is come around to the idea that physicians should have some ownership. So I don't think it's a problem.
Yeah, and Joe, I just want to add that in a lot of hospitals have competition, right? I mean, yes, there's some one hospital towns, but in hospitals where you have one or two, competitors, I think making the move and doing this is a competitive advantage if your competing hospitals are not. And if your competing hospitals are doing this, you should do this, because I think it's going to benefit whoever's doing this is going to have a benefit. So
Yeah.
in the long run. So just moving on. So the next slide is mini PSA plus. I'm just going to cover this just for 2 minutes and let Anjana finish it up with the last concept here. But in this private equity partnership model, whether they're physicians who left the hospital or private groups in the community partnering with private equity, in addition to these contractual arrangements down here at the bottom, if you go all the way to the left, we are involved in discussions right now with both cardiology groups we've advised on private equity deals and hospitals where they've had cardiology groups that have partnered with private equity talking about joint venturing on an ASC. So it's kind of putting together a couple of concepts. It's in addition to these agreements, there could be even tighter alignment by, like, if they're going to the private equity platform for various other reasons, some of which the hospital can't compete with, but one of which is capital to build an ASC. Having the hospital be part of that, I think, is something in most cases the doctors are agreeable to. Usually it's a minority interest, not the 51 thing, because there's a private equity partner. But having hospitals participate anywhere from 10 to 25 or even 30%, I've been involved in discussions and have seen those types of ventures. And the last point is it's possible, maybe not likely, but we've had also been involved in some early discussions about hospitals maybe wanting to have some rollover equity, if you will, some equity to invest in the private equity platform that its cardiology group in the community has partnered with as another way to demonstrate alignment. I've seen this happen in other specialties. It hasn't happened a lot. It may not, but it is something that out there that's possible.
I know we're going to move on to Anjana, but I will just say one thing here, Gary, which is this is kind of what I was talking about at the front, that the models that are out there are things we couldn't have even imagined just 5 years ago, that hospitals would want to even think about investing in a PE platform that's now assumed the financial responsibility and partnered with the local cardiology group, and these players between private equity or non-equity MSOs, the group, the hospitals, and in many cases then a third-party ASC developer. They're coming together in really new and creative ways that we just haven't seen before. And it's this right here. If you print it out and laminate it and leave it out at the bar at the next MedAxiom conference, it will create more conversation than I could imagine, just about, would this really happen? How do we do this? Would we want to do? It's just a great conversation piece, and you're living it. So thanks for sharing that with us, because it's completely intriguing to me, completely. But I don't want to take up all the time. Anjana, let's go back to you.
Yeah, let's go to the last slide. This is the last affiliation model we want to talk about. And this is basically a hospital that has either itself or through an affiliated entity, management services organization, or an MSO. And the hospital essentially is providing certain practice support, infrastructure, or other services to independent physician groups. It's not a model or that you see a lot. I think where we've come across it is, with respect to really small cardiology practices that are still independent, or in rural areas or areas where, like, it's hard for the independent physician practices to get this support in that geography. And the closest sort of bigger organization that can do it and has the capability is the hospital affiliate. Under this model, basically the physicians pay the hospital, so not the other way around, for those services, and they remain independent. The other variation I've seen on this, which is also not that frequently, is that I have seen it where a number of independent physician practices come together. They form what's known as a supergroup, essentially. And then it's a supergroup that is contracting with the hospital MSO for essentially purchasing some of these practice support and infrastructure services and things like that. So not and it's not a one size fits all. I mean, there's just so much variation on what is actually purchased and what it covers and all of that. But we have seen it from time to time. And like I said, you see it mostly with smaller independent practices or practices in sort of more rural areas. Okay, I think, Joe, we can turn back to questions if there are any more.
Well, we have about 5 minutes left, and I would encourage everybody to please submit your questions again through the Q&A button, not through the chat. And we'd love to take those as they come in. Anjan, I want to go back to how you kicked us off, if I could, though, while I'm waiting for questions to come in. You spent a lot of time talking about metrics and talking about co-management metrics, and I thought it was a beautiful, very thorough analysis. But one thing you said that we didn't spend a lot of time on was physician participation. And how is it that you choose physicians to participate in those co-management arrangements? I could imagine there's usually some pretty strong personalities that may want to come to the table that the hospital may want or not want. The group has its own leadership formation structure of how it wants to do things. And both parties really need to agree on who's going to assume those roles. So what does that look like? And how often do those change out compared to metrics, which change out every year or two or three?
Yeah, I think, we get this question a lot. And very often it starts with, well, Dr. So-and-so refers a ton of work to our hospital, and we really want him to participate, or, because it's important that, we keep him happy, et cetera, et cetera. Participation should not be based on referral volume. It really boils down to which of the physicians are going to be willing and able to commit the necessary time in a co-management arrangement, right? And I think, when it's independent physicians, yeah, I think you really have to do that assessment because they have their own practices, they're doing maybe other things with other hospitals. You just don't know, right? So I think that's one thing you have to look at closely. And on the flip side, when it's employed physicians, it's actually, this is why this model works really well also, with employed physicians, is because they're full-time employees of your hospital. Basically, you can predict, how much time and effort they're able to commit. The issue we run up against with employed physicians is really it's a fair market value issue, meaning that, the physician already has an employment agreement that says you're going to do X, Y, and Z. They may also be participating in other sort of hospital committees, or, there's things going on at a more sort of global level. And you have to make sure that under the co-management arrangement, they're not getting essentially double paid for doing the same thing. So, but that's something that you can work through with a valuation consultant who is usually brought into these things to help set the compensation. In terms of, more the personality and things like that, I think, again, it has to be people willing to work, spend the time. I think we see when it's participation by independent groups that you often see, at some point there is a change out, and I think it really aligns with what's happening within that group practice. Do we have a more senior level physician who was initially participating and now is kind of taking a step back, and then you have the next generation. So we see kind of aligned with that. But yeah, it is a question that gets kicked around, and obviously a lot of people have a lot of different opinions on who should participate. I think there's also that question of, if you exclude people, what is going to be the impact of that? So you have to kind of work within the legal sort of compliance guidelines, but we all know that there's a practical, business considerations of who to include and who to exclude.
Well, thank you. I'm about to ask you guys for closing thoughts. There was another question that was asked, which is how have value-based care payment models impacted these arrangements? I don't think we have the time to dig into that. That's something we can certainly follow up with. and value-based care certainly will play a role in some of these things and co-management metrics and so forth. But unfortunately, we are at the close of our webinar. So I will ask you, Anjana, for any parting words, and Gary, and then we will end today's webinar.
Yeah, Joe, I think I will just kind of leave it with what you said, or reiterate what you said, is these models, some of them have been around for a really long time, but the key and interesting aspect is like how they're evolving as things are changing in the healthcare world, right? You're seeing new twists and turns and variations. So I think it's just important to keep an open mind and look at everything, you know, as an alignment strategy.
Excellent. Thank you, Gary.
Yeah, on the question about value-based care, the metrics can be value-based care or oriented. So that is definitely a way to work value-based care in. But my closing remark is just that, you know, don't have that knee-jerk reaction to private equity. But more importantly, be proactive, be on the cutting edge of engaging with your doctors now that they have all these options. Just be proactive, and the more you can engage with them and align with them on ancillary services, I think the better off you're going to be in the long run.
Okay. Well, thanks to you both. It's been a wonderful webinar, very thought-provoking. I appreciate it, as does the membership. This will be available, and we will send out the link in a follow-up email with a recording as well. And other than that, I appreciate you both, and this will end today's webinar. So thank you very much, everybody. We'll see you soon.
Thank you.